Thank you. And it's a very fantastic panel that we have right now. And the topic of the panel is fantastic, actually. I mean, something very flashy topic, achieving dramatic insights into molecular oncology and precision medicine of non-small cell lung cancer, MTB. And my first reactions when I first looked at this topic, there were two words which caught out the attention. One was the drama, the dramatic insights, and one was the precision medicine. My subsequent reactions on this two things was, I mean, if you really have to look at what does Dr. Sandeep D'Souza want us to discuss is, for drama, he wants me. So, for entertainment, he wants me. And for precision medicine, he wants Kumar Prabhash. I didn't know, I mean, next time, Dr. Sandeep, you should get glamour also over there. Nikhil Gadiyal Patil is there. So you will have a combination of all these things. And now that makes sense why this exactly was done. For Vijay, we will make an ultra dose thing also over there. Next time I came, I thought, let me finish with Kumar's side of jokes first. I'll come to your jokes later on in the next conference. Okay, so let's get on to the job. We have a case. I'll start with the more serious one over there. I'll start with Dr. Bhavesh first. So we have a 55-year-old male who's a non-smoker, stage 4 non-small cell lung cancer, adenocarcinoma. A PET scan shows lung mass with multiple skeletal metastasis. MRI brain was normal. PDL1 was 80%. So in your practice, what do you order? I mean, do you get a single gene testing? Do you get a short panel NGS? Do you get a slightly larger panel NGS? Or do you get a patiala panel NGS? I mean, that is what I have now randomized into small panel, medium panel, large panel, XL panel. And you can also, for those who are dog lovers over here, which panel, small, medium, large, XL? Shefali is grinning away to glory on this. Amit Verma is not even looking towards me. Said, what kind of NGS are we talking about? So, Dr. Bhavesh, small, medium, large, XL.
So we go for at least a 12 gene panel.
That will be a short panel, medium panel, large panel.
Medium, you can say.
The coupon panel, as I normally call it over there.
Yeah, that's more feasible for us.
So, Dr. Sunil, I'll skip this question for you. Nikhil? Small, medium, large patiala.
So how do you define this slightly large?
Okay, so 12 gene panel is small panel. Slightly large is what we do, 35 gene panel. And, so it is single gene testing, EGFR cross, 12 gene coupon scan, 32 or 35 is the one hotspot that we have. And then the patiala panel is what Foundation or a Guardant will give you.
So currently I'm sticking on to 12 gene panel.
So currently you are onto the medium size panel, actually, if I call it. Dr. Kumar?
So at this moment, I would prefer a large.
No, sir, what are you doing?
Or what we are doing, a small panel or single gene, either of them.
So you're also into small or medium size panel
at this moment, yeah.
And Vijay will obviously, Vijay will get an ultra small panel. The kids section over there. Is that also okay, Vijay?
Unit policy follows.
Unit policy. This is the standard answer, unit policy follows. So, I always tell my DNB residents, एग्जाम में कुछ पूछने ना बोले कौन सी कीमो देते हो बोलो एसी टैक्सोल बोले क्यों हमारी हॉस्पिटल में यही होता है so the unit policy follows. Okay, but Kumar, if given a choice, if you have to expand this panel to your setup, what would you do? Your setup in Tata.
Yeah. So yeah, it's my setup in Tata. So yes, large.
Till now Tata.
Unless Ullas gives me a job.
I have to give you a job, sir. Come on. Kahan Raja Bhoj or kahan Ganguly? Okay.
If I have to, then large panel. And I'll give you a reason. You want
the large or the Excel?
Excel.
The comprehensive gene.
Comprehensive.
Panel. But do you think that is possible in Indian scenario?
It is possible. If we with the same cost which we are doing, it is possible. If we get out of the mindset, and if the clinicians and the lab, they collaborate. I do remember when I used to talk about short panel also, I used to get the same question.
Yes.
How, Kumar, it is possible? And now we know that it is possible. My stand remains the same, because if you have, and I see there are lab people here, they can second me. If you have a NovaSeq with you, and if you can put all samples into it, the cost of the test which you get out.
How much cost will come down to if you get in Indian scenario, if you put all your samples into that, how much will it reduce down to?
So you will have this Excel panel at the cost of around 15,000 odd.
15.
Yes.
Honestly.
You will be able to put 300 samples there.
And the TAT will be how
I'm
much?
saying Novasic. Remember, I'm saying Novasic,
saying Novasic.
all sample in one go. Remember, there are caveats. Caveats is that all clinicians, they say, hey, patronize a lab.
One or
Give
two
them-
labs, basically.
Patronize the lab, give samples to them so they have adequate samples. So I calculated, I sat with one of the private lab, they have this, and then they said, Kumar, we don't get this.
And TAT,
Sorry,
turnaround time?
turnaround time. If you have the lab, you
If
will
you
get
have
it.
the lab, you will get into
Because,
it.
because usually you have a pipeline today, if they have usually good software, and you will have issues. Run of the report you will get within a week or 10 days. That today you get a report which is late primarily because they don't have those
Samples don't are
samples. That's the
So
key.
just for the other people, I was saying the normal people who are sitting over there and the abnormal people who are sitting here, single gene testing will probably cost us nothing right now today nowadays. The short panel NGS costs around 10,000 or 8,000 to 12,000 in the routine practice. The slightly large panel that what we have, Thermo Fisher Oncomine panel, which we have monitored for us, costs us around 25,000 rupees. The CGP or the Patiala panel right now costs a lot of money.
Can I add to that?
Yes.
Now, what we are forgetting that when you do this now, you're not taking the Oncomine panel, you're removing the IP part.
Yes.
See, when your Oncomine is giving you the panel, he's putting IP to it.
Yes.
Why you require IP? You know,
So, Kumar, the next question is, why do you require the Patiala panel? So the other next question is, because your short panel NGS and the slightly large panel NGS will include everything of interest right now.
Yeah.
Why do you want, unless or until you want to look at the co-mutation at the PIK3CA data, why do you need a Patiala panel?
So what happens is slowly we are learning. It took us time to realize ALK can be also pan tumor.
Okay.
BRAF can be pan tumor. So if we slowly break it, so
Okay.
for example, we do have PI3K, you have a problem. I do agree with you. PI3K is a problem. PI3 is not the same everywhere. Is BRCA looks like everywhere? You know, if you have a somatic or germline, BRCA, whichever way you put it, as on date, I haven't got a tumor where BRCA is there, those classical mutation, and you don't see a response. What I'm saying when I say this, I do understand when I say this that I am stretching things a bit, but with some suggestion in the past, what we have gone through. If I get more information with the same cost, not first line, don't give in second line, but in third line, just I was talking to my colleague, Dr. Preeti, and she gave an example. AML, FLT3, Dr. Banavali has been talking for last 10 years, and this is sad that we didn't implement it. Now there is international data. And he used to give sorafenib and used to say, sir, are you doing right? And now data is also there. And just now she shared with me, the person was not able to afford routine treatment for AML. She gave sorafenib 4 years down the line. Am I right, Preeti? And patient's doing good. So what happens is that these kind of information, it is not big number, but out of few hundred, if you get 2, that is a good story for that patient.
I totally agree. And, I would, so what we have the large panel right now is also because of Kumar's vision that we could do it in the RGCI. Kumar at 5 years back used to tell us, get out of single gene testing, come to at least large one. We did that. But I think what you're saying makes sense. And hopefully in 4 years, 5 years, in the next conferences to come, we will go towards the Patiala panels, and which will really show us the way forward over there. So we'll go ahead. For the uninitiated, this is what you do. This is a routine single marker test in which this mutation is basically found. The others are missed here. This is what I call as a short panel, the small, the medium or the large panel. It will look for only this, look for this, look for this. So these mutations which are in between will be missed. But if you do a comprehensive genomic profiling, that's a CGP, which is music to the ears of all the pharma people and the molecular lab people who are sitting over here, you are by and large less likely to miss out on things. Now, how much that is? Is it 2%, 3%, 4%? We don't know. But till the time you don't do, you will not know. I mean, that is what Dr. Kumar is saying. Yes, Vijay.
So my question is, when you go for comprehensive gene profiling,
Vijay, you are muted. In the unit policy that if Kumar speaks, everybody is muted?
No. So do you think there will be a difference in depth of coverage when you go for multi-gene, and that the chances of finding which is relevant increases in the multi-gene, as opposed to the chances of missing a relevant thing, there might be a risk in comprehensive gene if you don't take that same depth?
So what he is saying is about the depth of the coverage and the reads that you'll have to do, Kumar.
So this is a very valid point. So that's why I used a specific machine name. So if I do a comprehensive genomic profiling in mini-seq, maybe most like I'm fooling with my patient and relatives. If I'm seeing my-seq also, I'm fooling with my patient, and your numbers of patient sample will be too low and too costly. And that's why I put a specific machine where good number of sample, you will be able to do it with reasonable cost.
Okay, so just for the summarization, I've said you use a small panel when you're looking for expected things. You say, okay, boss, I have 10 medicines for this. We have KRAS, RET, MET, everything. We want those. So you use the hotspot panels, which is basically a diagnostic using tumors with known actionable biomarkers that you don't miss out on them. Their cost constraints, tissue constraints, you require faster results. Definitely a small, medium or large panel will be required. Large when you don't know what to look for. It's like, okay, fine, tell us what you're looking for. A molecularly heterogeneous tumor with not many actionable targets, when tissue is not an issue. Results may not deter ongoing treatment line. You said, okay, fine, we may have 30 minutes, we may have 2 weeks, 3 weeks to come. If cost is not an issue, and with research intent, definitely it is required to do. So again, small panel, large panel, whole genome, whole exome sequencing is something we will go. We will, I think, skip these things. I have said this many times. But if somebody can, Nikhil or Vijay can tell us. So this is the status of NGS reports and companies offering NGS in India. Everybody says, I am the best, I am the best, I am the best. It's almost like you go to a market and whom do you want to patronize? We don't know. So let's discuss the common terminologies or medical jargons. Vijay, you spoke about depth and coverage. Let me just ask you to please speak about VAF, depth, coverage, etc.
I'll let Dr. Kumar speak.
Let Dr. Kumar speak on that. The Kumar is always there. When Kumar is there, and then Nikhil, you tum to mujhe aisi bolte main bolne nahi deta. When Kumar is there, Kumar doesn't let anybody speak. Okay, Kumar.
My apology.
So for all the juniors over here, this is the next 3 minutes are going to be very, very important, because that is what you should look in a report. The VAF, the depth, the coverage. How to read an NGS report? A master class from Kumar. Next 3 minutes, Kumar.
So I'll try that, and there are people in the audience, sure, they can help me. And so variant allele frequency is whatever you got as compare whatever you have seen. So for example, I say EGFR exon 19 mutation. So you have read the reads, you have seen how many had it mutations and how many you saw. And that is what you calculate, and you can put number, you can put percentages. Usually percentages is something clinician understands. So that's why our lab people put as percentages. So that is for understanding.
So Kumar, VAF is about EGFR. Let us say there is VAF of 50%. That means EGFR del 9 about all the EGFR wild types, or EGFR del 9 denominator will be all mutations or whatever it is.
Yeah. So VAF will be not the mutation, all the reads which
all
has been read.
So that's very, very important. It's not only the 50% of EGFR, it's about all the mutations.
So one more catch is that many times you have a bit of a different way of calculation. People can see the reads in that area, how many times it has gone. Sometimes they say read anywhere they have gone. So many times what happens is we think when we have NGS testing being done, they read everything.
Yeah.
Not
No,
necessarily. It can be parts. Sometimes it is read in some when they are reading this gene. Sometimes they have not. So sometimes they calculate based on that gene how many it has been time read and how many times you have mutation. Then you divide it. Other time people usually do it how many times mutation and whatever has been total times.
What is the depth of the coverage, Kumar?
Depth of the coverage, how many times it has gone through. So you buy 100x, 200x, 300x. So how many times it has gone through? I'll just give you an example to remember so that So you will remember 1000x from a good from a lab. You want to put your lab guys in discomfort, ask them how many they removed it. So you have so many dirty or useless things which comes out. Usually that's why you read 250x is good enough and lab writes 1000. So you're impressed. No, your lab is giving you half information. So there are 30-40% of them are something which is not useful and they remove from the calculation, and finally it is 250 to 500x what we do.
So what is good enough for so let's say a normal person like us reads over there in an NGS report, what is the depth of the coverage depth, which is?
So at least it should be 250x. If it is less than 250x, definitely you have an issue.
And what about the liquid biopsy?
Okay, liquid biopsy, if you do it, the depth of the coverage, if it is 200x, not a good idea, unless it is 1,000, 10,000, be careful. 1,000 also may not be enough. We have got problems with 1,000 also.
5,000, 10,000.
Yeah, maybe 10,000 or 20,000x. That's the kind of depth you should have.
Okay, Vijay, you had a question for Kumar.
So when you look at WAF, when would you say that this is significant?
So
And
WAF,
second
what percentage is it significant?
And second is, can from the WAF you tell whether this is germline or somatic?
Okay.
So two things. One is, when do you say significance? Traditionally, remember 5%, but not necessarily. Discuss with your lab people. 1% can be, think about if you have an exon 20 L858R, 1% is also useful. But if you have a relatively uncommon unknown in lung cancer, so for example, if I get a BRCA mutation in lung cancer, then I'm concerned. Then 1% I will be concerned
Not
about.
very good.
So which is well characterized, then 1% also good enough. But 5% is something ballpark figure. If less than that, have a discussion with your lab people.
Okay. So we have some questions. So this is, I mean, just kept a Rajiv Gandhi report for publicity of Rajiv Gandhi people, number one, and just to show that, how an NGS report is done. So a good report has to be, a diagnosis has to be written. A very important thing is, write over then please, for all the young medical oncologists, what was the tumor fraction in the submitted this thing? I still remember we had a tumor fraction of around 10% and the ALK report was negative. It was from another person. We got an ALK by IHC, then it came positive, and we had great things over there. So this is very, very important, the tumor fraction. This is important. Then you report the DNA mutations, whether KRAS hai, TP53 hai, jo bhi karke hai. It report highlights will give an overview of the alteration. Then you look at the DNA sequence variants, and you look at basically the gene fusion. I'm just telling you how does a good NGS report by and large looks. This is WAF, which is basically mutation burden. It is the wild type counterpart, 33.07 here. And then you have the gene fusions, the type of the fusions, the partner, the exons. Again, very, very important is, so this is the NGS Smart Lung panel that we have written. Read about what genes were tested. I still remember initially we got an NGS done for lung, and we thought NGS हो गया तो BRCA होता होगा. हमें क्या पता कि उसे BRCA थोड़ा करते हैं. I shouted at a pathologist, यार BRCA नहीं किया तुमने उसमें? Dr. Ullas, वो तो होता ही नहीं है. I said, क्यों नहीं होता? You are making a Mickey out of us. And I had a tongue test with them. But then little I realized that it is not their fault, it is our fault. We didn't know. I mean, I didn't know that NGS does not mean this. So you look at all these things which are there, genes analyzed for SNVs, for rearrangements, quality metrics which are passed. So this is all something which we need to basically have to look. But that was all about this. Now let's come to the cases that I have kept over here. A 65-year-old male smoker, diagnosed as stage 4 non-small cell lung cancer, squamous cell carcinoma. Sunil, P40 positive, TTF1 negative. कोई शक? Squamous cell है? कुछ और तो नहीं करना है? Okay, fantastic. So when in doubt in Rajiv Gandhi in pathology, ask Sunil. Sunil will look at the slide only and tell कि squamous है कि adeno है कि इसमें कुछ नहीं है. No, I'm telling you. I mean, this is what happens. The PDL1 was 60%. We are not discussing that. PET scan was done with said lung mass with pleural effusion with multiple skeletal mets. Disclaimer, from now onwards, there are 4 cases. Everybody will have lung mass with pleural effusion with multiple skeletal mets because the slides were made yesterday night. The options of treatment now, Dr. Bhavesh, I'll come to you again. Pembro and chemo, 407, alone, 2442, checkmate 9LA, chemotherapy followed by second line IU, any other. What is your take? Just one this thing.
So I would like to go for Pembro alone.
You would like to go for Pembro alone. Fantastic. Nikhil?
So I will have 2 options here. One is Pembro alone. Secondly, of course, the CM9LA.
So Pembro alone and CM9LA.
Yeah.
This any other is for Vijay Patil. Ultra low dose. Alto chemotherapy. Neo Alto was there.
Even if it is squamous, I'll get a mutation analysis done.
You'll get a mutation analysis done.
And if that comes negative, then only I'll go with
Okay, Kumar.
immunotherapy.
But options?
My option in this case will be this,
Vijay, please speak on the mic.
Pembro and chemo.
Pembro and chemo. So we have one Pembro chemo, we have one Pembro alone, we have one checkmate 9LA and an NGS. Kumar? Anything is okay.
NGS and then
NGS and anything is
one
okay.
of those.
Fantastic. So this is what the patient was tried on the Keynote 407 regimen. The PET CT scan after 4 cycles was partial response to treatment. He was continued on pembrolizumab maintenance. PET CT after 8 cycles, it showed a progressive disease with increase in effusion and new lymphadenopathy and bony lesions. So what to do when you don't know what to do? Nikhil, what will you do now?
I will try and see whether I can get biopsy one more time.
You will try and get a biopsy. So we got a biopsy done. It came as squamous cell carcinoma again from this thing.
With NGS.
With NGS. Why are you so apologetic towards doing an NGS? Okay, Bhavesh, will you do something differently?
No, here we want to know what went wrong. I mean, it is too early.
I don't want to know. Patient wants to know. Patient wants to know that after 15 lakh rupees, what went wrong?
So definitely we want to see much more. Anything else we can target for?
Yeah, this focus basically what the patient was pointing at me. You know that you said everything will be absolutely okay. So as Kumar and Vijay have very rightly said, the patient was tried on chemotherapy. Very reluctantly, I ordered a biopsy which came as squamous cell carcinoma, P40 positive again. It was sent for NGS, and the NGS report basically came as this. A MET exon 14 skipping tier 1A mutation with a variant allele frequency of 8.7 and 10. And just when you thought your job sucks. So my question here to not Kumar and not Vijay and to Nikhil and Bhavesh is, and that's a very, very pertinent question that I have asked right now. In squamous cell carcinoma also, is it time to incorporate the NGS in the first line before you start a chemoimmunotherapy? Nikhil.
So guidelines still do recommend bit of a testing as of now.
Guidelines recommend
currently we are as of now
the NGS testing.
not NGS. Some of the like EGFR and other ALK and ROS1, like if you go for the NCCN like guidelines. Currently, I'm not doing it, but at the same time, at some point in time, the way we discussed previously, that there will be a time where almost all the patients
So
would undergo.
what stops you from doing it right?
So again, the way probably we look at maybe the non-squamous histology and versus squamous, there is still a bit of a
the number
difference.
of patients
Yeah,
are down.
much less, and that is one of the reasons why we are more inclined for or other types rather than this
Dr.
one.
Bhavesh, do you and will you?
I
You
would,
don't obviously because you said there's nothing. Will you is the issue. We didn't till the recent some time.
So definitely counseling will be done about doing an NGS, but maybe patient if not affordable or patient does not want to.
If
go
it was
for that,
adenocarcinoma, patient will agree, no?
at
I
least
think
for the
it's
12
more in the mind of the clinicians to tell them that we like, both Vijay and Kumar, they made a protocol. So I like to hear from Vijay. Is it a protocol now in your unit to do an NGS and not start immunotherapy even it's a squamous?
If the patient is affording, we would want an NGS to be done.
You would want an
And
NGS.
If the patient is asymptomatic, we'll wait for the. I always remember sir teaching us also when the IPAS study came, there was another paper which came just below the IPAS, which actually showed that there's 7% in incidence of EGFR mutation in squamous.
Yeah.
We have published our own data of EGFR mutations with squamous, and they behave very similar to the way non-squamous would behave. So I think
I would totally agree with Vijay and Dr. Kumar. Kumar, I'll come to you in the next case. I was a non-believer, and I will place it on record, Kumar, the Tony Mock session over there. I still remember Kumar had the guts of telling Tony Mock that in squamous cell, EGFR mutation do exist, and there was a lot of gemi, if I remember, and I was not in his side. I apologize for that again and again. But again, we have done, yes.
The patient is a smoker here. So
Doesn't make a difference, Dr. Sunil. Doesn't. So we have done a whole exam sequencing, which Dr. Kumar is aware of the data. We have got a 3.8% rate of EGFR mutations, small number, 72 patients. We have got 3 ALK, we have got 4 MET, this thing, then we have got 1 BRAF. So the idea over here is as more and more we do NGS in squamous cell carcinoma, it is worth doing. I'm beginning to get convinced, and we are going to pull up our data and tell that I think in squamous cell, before you go on to immunotherapy, we should do an NGS. Whether you do the patiala panel or whether you do the small, large panel is something to be thought about. Yes,
There's something exactly what I have been discussing. Like, no, we are doing few genes, but not like those even for
so
12 or something.
few genes that we have are the ones which are targetable in this thing. But I think I'm with what Kumar has said, I will go ahead and do.
So something like EGFR is something what we definitely do for most of the patients.
Yeah. Okay. So the Indian data, I didn't get the slide over here, but that was one very important case that I wanted to bring up right now. Because I think time has come to do squamous cell, and when you're giving immunotherapy, definitely. I think Prabhat Malik was there. I quote him also. They asked him a simple question: is there a biomarker for immunotherapy? He said there is only one biomarker for immunotherapy, and that negative biomarker is presence of a mutation. So if you have a biomarker positive, probably you will not really respond to immunotherapy, and I'm beginning to get usually very, very convinced for that. So the other one, a 55-year-old male diagnosed as stage 4 non-small cell lung cancer. PET CT scan shows the lung mass with adrenal and bony mets. Okay, I changed it. I only didn't remember. I thought it was same pleural effusion and multiple bone mets would be there. It was ALK positive by IHC. NGS not done. Did we miss a trick, Bhavesh? Positive IHC, this thing not done. Is it okay?
Ideally, we should have done.
Ideally, we should have done. Fantastic.
I mean, EGFR also, there is a minimum EGFR.
No, we did EGFR and ROS were negative, or ALK was positive. We didn't further do the IHC. We didn't further do the NGS, so that's okay. The patient was tried on alectinib 600 mg BD. Roche would be happy. Tolerability well. PET scan after 6 months, partial response to treatment. PET scan after 15 months, a progressive disease in the form of new lung nodules and supraclavicular lymphadenopathy. It's a progressive disease. Pfizer will be happy now. The patient will be very unhappy. The MRI brain was normal. So what do you do now? We'll start with Dr. Vijay. So ALK positive IHC, variant, forget about it. We have got a biopsy done. We have got a ALK IHC positive, alectinib. Now the scan is showing progression. What would you do now?
I would send for the resistance mutations.
You will send for the resistance mutation after alectinib.
Yeah. And I would offer the patient lorlatinib.
You will offer the patient lorlatinib, but you will do a biopsy.
Yeah.
Dr. Kumar?
Unit policy doesn't change.
Unit policy doesn't change, especially since somebody else, a junior has said, the senior to bilkul karega hi nahi karega uska. Nikhil, will you biopsy? And the patient will ask you, what are you going to look for in a biopsy? It will still work, Nikhil.
So no, just now started.
Work, not very.
I would agree with what Vijay just now mentioned about planning resistant mutation as well as this one, but biopsy only for if at all I want to rule out some other. And this patient has got supraclavicular node, so rule out any transformation.
Fair enough. Dr. Sunil, how many times have you seen a small cell transformation in a ALK positive? In EGFR on TKIs you see, but in ALK positive, do you really see that?
Although very rare, but
you never know.
Yeah,
so,
but we have seen that.
Dr. Bhavesh, will you do a biopsy? Clinical practice.
Yes, because the site is very easy to biopsy, supraclavicular lymph node. We can take that and send for biopsy.
So I know biopsy and NGS was the dramatic insights and personalized medicine. I knew everybody will say biopsy. So we got a biopsy done. The patient was tried on, patient was tried on lorlatinib. So the slides were made yesterday night. That is why chemotherapy came. Patient was given lorlatinib. The biopsy came as NACLC NOS, and we sent for an NGS. And the NGS report basically is now showing this mutation, which is L1171I mutation, and we didn't know what about this mutation. So we spoke to Dr. Google, and Dr. Google basically said this L1171I mutation is basically resistant to alectinib and is sensitive to serotonin. अब जिसने biopsy की थी ना, अब बताओ क्या करोगे? We'll start with you, Dr. Bhavesh. So the patient is already on lorlatinib, but this mutation or patient was being planned for lorlatinib, not started as yet. And now there's a mutation which may be sensitive to serotonin. What would you do?
So considering this data, probably we may shift to serotonin.
This data is only for some 3 patients. Okay. Dr. Sunil will skip you. Nikhil?
So I just don't know whether the lorlatinib has an action against this. But
Lorlatinib is a designer drug. It has
so
action
it's a
against
pan LK, but not.
So then why
specific.
did you do a biopsy?
No, it was for something else. Small
What
cell.
area?
Small cell.
Okay, it was a small cell. Okay. It was not
So
for
I am not wrong on that
okay,
part.
okay, fair.
But I'm not. But if at all I have that information, I can think about it. Else one can consider use
So
of
one
this.
serotonin, one can think about it.
Yes.
Dr. Kumar?
So in last tumor mode, we had a case.
Okay,
And it's the
fantastic.
same one. And I'll tell you the discussion what we had. So catch is here that this is a mutation most likely after crizotinib. So after crizotinib, then you have a decision-making issue.
Yeah.
There is a possibility that you had this mutation
Before
after,
too.
before only and after alectinib. Now, after alectinib, if you have this mutation, now is it sensitive to ceritinib or not? We don't know. But finally, with all our discussion, it was decided if patient is asymptomatic or not, that patient was asymptomatic, large volume disease or not, patient had a small volume disease. So decided, hey, give ceritinib, evaluate CT scan after 4 weeks so that you don't lose the chance to give the further treatment. So you are able to safeguard the patient
So the
interest.
unit policy remains the same. And for once, I am very proud of the fact that our tumor board also saw the similar way to your tumor board. We gave this patient serotinib. It's been 7 months since the patient is on serotinib. The patient is responding very well to treatment. So we have, yes, Nikhil.
Add that genius thinker like that.
I don't know. The two genius sitting over here.
You
No?
can't have multiple people pulling legs.
So, the moment I had this NGS report, I still remember. I don't know whether Mansi is there or not. She told, क्यों भेजा था NGS? मतलब बताओ, लौलाटे दे देते. So that was like, तूने क्या किया करके. So this was the option of treatment. And just in case you guys thought your job sucked, this is also a job that some people have. Let's just go for the third one. And we have 3 more minutes. 87-year-old male. By the way, Dr. Sandeep Jasuja, this is after a long time I made some original slides. So, for your conference. So 87-year-old male, surgery for lung at the age of 82, 4 cycles of chemo, recurrent disease. A PET scan was done which says lung mass with bilateral lung nodules with bony lesions. I was hyperactive in the night. So I wanted to make some stage 4 diseases over there. Biopsy came, NSC, LC, NOS, sample sent for NGS. We can see it's an foreign wala, patiala panel NGS that is there, which is now showing BRA V600 KE. It's not it's a non V600E mutation. So, Dr. Vijay, it says it will respond to trametinib. It's a non V600 mutation. Non V600. Okay, V600 K wala mutation hai ye. Which is sensitive to trametinib. I think she didn't show in her slides, but this is one thing which may respond only to trametinib and not really to dabrafenib also. What would you do?
I will take this to the molecular tumor.
87-year-old.
Molecular tumor.
Molecular tumor board. You're sitting in molecular tumor board?
So I'll give it to him.
We'll give it to him. That's the easiest one, no? What we'll do is we'll put a photograph of Kumar over there in all our OPDs, no? Yes, Kumar, what would you do?
I wish I knew, but I'll tell you the thought process knowing this. So there is a thought process that if you don't have BRAF, if V600E usually don't respond. But there is a thought process that if you block below pathway,
Below what?
MEC, then there are responder.
Yes.
People have tried. People have colon cancer.
So the thought process was right. It was he was an 87-year-old male at that time. And we thought, what is the harm? I mean, anyway, he will not take chemotherapy. We thought, what is the harm in giving him something? And we actually gave him both. Dabrafenib and trametinib also. The person has responded for 2 years right now. And we are going to, probably publish this literature over there. And this is something which will basically show the slides were made yesterday. A 45-year-old male, stage 4 non-small cell lung cancer, biopsy adenocarcinoma, sent for single gene testing, EGFR, ALK, both were positive. Why I am putting this question here is because there was again a beautiful publication by team MH group in which they have given option about how to manage concurrent EGFR ALK positive. So it's a double trouble. I'll ask Bhavesh and then we'll go to Kumar.
So actually here, I would like to ask that what was the percentage wise, which was more?
Single gene testing. NGS report awaited. I knew this will come, no? That is why I have written over there, confirmed by NGS. Both were positive.
If we don't know which is the major contributor, probably at this point of time, maybe start with ALK followed by EGFR.
Okay, Nikhil? Very nice article. You guys should read Acta Oncologica by Vanita Narana and the group. I would suggest. I mean, you should not call them team chess group or the group, THE group. Yes, Nikhil.
So I think if you don't have these copy numbers over here, maybe I would probably start with the anti-EGFR, and but I will have an early scan for this patient.
Okay, so this was the study which was published in Acta Oncologica just 4 days back. At least it came on Twitter and Facebook in 4 days back. So that is how I remember. So this is the survival curve which said, and they said ki as long as the patient gets both, the survival is much more higher. This has received both TKIs and this has received either one or neither TKIs. And in the final set, they said there were some few patients in which they gave both. So you can actually, 1 minute. The dominant driver could be the dominant driver dual. This thing is ALK. Targeting both molecular drivers also is an attractive option, and I think you guys have done it before. We have had a patient in which we have given osimertinib plus alectinib, but that was a resistance to osimertinib. Tolerability was good, but I think this is what you suggested at the end of this paper, Kumar.
I agree. This was our suggestion with the caveat.
Yeah. So this is we had one more patient, but I think we'll just forget about it. Okay, so forget about that. And just to conclude, I will just like to say learning is fun when it's a lot of things, but learning is actually fun when you're sitting on this absolutely gorgeous, fantastic panel. So thank you all the panelists for keeping us
10 seconds. 10 seconds. So learning is fun when Ullas is also around.
Thank you.
And one more thing I'll add, 10 seconds. And this is for the squamous cell part. So, not only Ullas is a dear friend. No one is to trust that. But we fought it. We said, no business. We have seen it. We have seen the report in our lab. We are not going to change. And not only here, in our own hospital, we got criticized. In our own DMG, we got criticized because we have people from our own hospital. So they can, that I'm saying the truth. We said, no, we have seen in the lab, we don't change. Because what I'm trying to convey younger people is that trust your data.
Look towards me also when you say young, no? So, don't look at that only when you
last I learned from him. So younger people, trust your data. If you have seen something in your clinic and something in your lab, trust it. Whatever may be. Dr. Chandra Bilani was from Jaipur. I had such a slanging match with him.
I know.
Finally, he just wanted to prove me wrong. He said, I have given treatment and no one responds. And before that, he had made a statement, I have never seen one. I said, sir, you said you never seen one. How come you say you have seen that they have not responded? So idea is that we said, no, if you have seen it something in your clinic, you have seen in your lab, trust that. Whatever someone else may say, that was the message.
The second, and
NCCN has changed now. If you take NCCN 3 years back, NCCN used to not recommend.
Yes.
Earlier there was none, then it was only non-smoker, female and others, and now it is all comers, and it has changed now.
And again, one important thing which Kumar has told me, and they said, don't base your data on the first 5 patients. The first 5 patients will always come negative. I still remember when you give nivolumab and lung cancer, kaam nahi karti hai. Give it to 100, 200 people, you will slowly come across the data. The numbers are absolutely smaller. The numbers are not that great. But again, you treat for 2% ROS, RAF, MET, everything. So I think EGFR deserves and everything else deserves to be treated. With this, thank you. Thank you for the learning. Thank you.